to help found the American Indian Cancer Foundation. He has led numerous studies and published multiple manuscripts on colorectal cancer in American Indians. He also serves on several cancer work groups, including the IHS Colorectal Cancer Task Force. Dr. Perdue and his family live in Minnesota.
Yay.
This technical assistance webinar is hosted by the National Native Network, which offers resources for cancer and commercial tobacco prevention and control throughout Indian country and the Indian Health Service Clinical Support Center. We are pleased to offer continuing education credits for participation in this webinar. Let's see here. No commercial interest support was used to fund this activity. The IHS Clinical Support Center designates this live activity for 1 hour of AMA PRA Category 1 credit and 1 contact hour for nurses. To obtain a certificate, you must attend this entire webinar and complete the post-webinar survey that will be emailed to you. By the end of this webinar, participants will be able to describe the disparities in colorectal cancer incidence and mortality and how this may be impacted by screening, identify the latest screening guidelines and methods, identify strategies that can be used to improve screening uptake. Questions will be answered during the last few minutes of the webinar. Please type your questions into the chat box on the lower right hand of the screen. And Dr. Perdue.
All right, everybody. You should say good afternoon. I'm David Perdue. Thank you for the kind introduction. I just make sure you can't see my title slide, correct?
I have switched the presenter to you. All you have to do is click show your screen.
That's it? You can see me? Or you can see it? Fabulous. All right. Well, welcome. It's a cold day in Minnesota. And very honored to be asked to come and talk to you about a lot of the projects we have going on in Minnesota, as well as just colon cancer in general. And we're going to get rolling here. Hey, if I can figure out how to advance. There we go. I've already been introduced. Again, my name is David Perdue. I'm enrolled in the Chickasaw Nation of Oklahoma, and I work in Minnesota. I've had a great introduction, so I'll move on. We're going to talk a little bit about epidemiology of colon cancer, the risk factors for colon cancer, some screening options, a little bit about barriers to screening, and possible solutions. I want everyone to keep in mind that 95+% of colorectal cancers actually follow what is called the adenoma-carcinoma sequence. What does that mean? It means that colon develops genetic abnormalities that lead to the formation of polyps, and these polyps are not cancer yet. We think that about 1 in 10 adenomatous polyps can develop into cancer. It may take between 8 and 12 years to do that, and we know that by taking these polyps out, we can significantly reduce colorectal cancer. This is a very complicated slide. Obviously, it's past the, I guess, level of what we're going to talk about, but I just want people to see that you start developing these different genetic abnormalities. You get methylation abnormalities, you get some tumor suppressor genes that go awry, and the next thing you know, this polyp turns into a cancer. Colon cancer is staged based on the depth of invasion of the cancer. So in stage 0 cancers, we're really still in the mucosa, and these are the ones that we can actually take out with the endoscope. So a patient comes in, goes home cancer-free. Once we're at 2, we're starting to get it, or sorry, once we're at stage 1, we're actually getting into the muscle layer. Same with stage 2, we're deeper. These cancers can be treated surgically and don't require chemotherapy, but by the time we get into stage 3, we've got cancer into lymph nodes, and by the time we get into stage 4, that cancer has spread to other organs. This is really critical because 5-year survival is completely dependent on the stage in which we catch these cancers. Again, if we get these cancers in the very early stages, it's over 90% 5-year survival. A lot of these patients are cured. By the time we get to the regional lymph nodes, it drops to 67%. And unfortunately, if we don't catch it until they actually have metastatic disease, 5-year survival is less than 10%. So let's talk about colorectal cancer epidemiology in American Indians, predominantly, and some about the Alaskan Natives. We look at the leading causes of cancer death in American Indians. Lung is usually the leading cause, but interestingly, colon cancer is actually the leading cause of cancer death in non-smokers. If you look at individual genders, men have more prostate cancer, women have more breast, but when you combine the genders together, colon is, again, the second leading cause of cancer death. People are often surprised to know that your lifetime risk of colon cancer is about 1 in 17. A little bit higher for men, but not much compared to women. Just this last summer, we actually published an update looking at colorectal cancer incidence and mortality, as well as stage among American Indians and Alaskan Natives in the American Journal of Public Health. In this project, we looked at colorectal cancer rates in what are called CHSDA counties. Most of you may know what that means, but for those of you who do not, CHSDA stands for Contract Health Service Delivery Area, and these are the counties in which the Indian Health Service provides services. So most people that receive Indian Health Service care or who are eligible for the Indian Health Service to pay for services not available at their local tribal health facility live in these counties. So these are counties that have a enriched population of American Indians, and this kind of maps out to where a lot of the reservations are, of course, plus the state of Oklahoma. And if we look at colorectal cancer incidence, this is the number of new cases in a population per 100,000 people, and we age adjust that, and we look at American Indians and Alaskan Natives grouped together. There are Alaskan Natives that do not live in Alaska. And we compare that to non-Hispanic whites. What we see is the following. For non-Hispanic whites, colorectal cancer incidence is pretty stable across all these areas. And again, if you look at the little map at the top right, you can kind of see where these are. These are Indian Health Service areas. And but what we see are interesting, dramatic differences among American Indians by region. We see the highest rates up in Alaska. Northern Plains and the Southern Plains come in second. And again, their rates are quite a bit higher than non-Hispanic whites. The East Coast data is a little bit rough just because we don't really have the reservations and things in the East Coast, so the numbers may play a role in why those are low. But if we get into the Southwest, they have colorectal rates that are significantly lower than non-Hispanic whites. And if we look at mortality by region, so the number of deaths per 100,000 people, not too surprisingly, we see pretty similar trends. Highest in Alaska, the Northern Plains, and the Southern Plains, and the lowest being in the Southwest. And with the exception of the Southwest, mortality or deaths are higher among the Native population than the white population. This is kind of a confusing slide, but this is a way of looking at colorectal cancer mortality over time using this fancy CDC way of looking at things. And what you see in the purple line is actually non-Hispanic whites going from 1990 to 2009. You see these rates have just been falling, and those rates that is a statistically significant decrease over time in non-Hispanic whites. At the same time, if you look at the red line, that's American Indians and Alaskan Natives. And even though the slope is somewhat upward, it kind of appears as if mortality rates are actually increasing, that change is not really statistically different. But so what that tells us is mortality really is not falling in American Indian and Alaskan Natives like it is in the white population. If we look at how cancer is staged or what the stage is when people are diagnosed, we see that if we focus on the left, that's for the United States, that American Indians and Alaskan Natives tend to be diagnosed more often with late-stage colorectal cancer compared to non-Hispanic whites. And on the right side, the data is just more specific for the Northern Plains, which is where I do the majority of my work. And if we look at age group, we also see that Alaska Natives and American Indians have a tendency to be diagnosed at younger ages. So while about 70% of colorectal cancer is diagnosed in individuals over the age of 65. Among whites, that's about 65% of those cases are over age 65 in American Indians and Alaska Natives. So a little bit younger skew. So major points here: colon cancer incidence, mortality in most regions is either increasing or not changing in American Indians and Alaska Natives, while falling in non-Hispanic whites. And American Indians are diagnosed at younger average ages and are more likely to be diagnosed at later stages of disease. So why? Questions are always about why this happens, and I think one of the major reasons is really that screening is underutilized. A lot of the fall in the incidence and mortality among the non-Hispanic white population has been attributed to the efficacy of colonoscopy and taking these polyps out so people don't get cancer, and finding these cancers earlier where they're much easier to treat and survive. There may be other factors. Risk factors may certainly be higher, and that's probably why we see these differences between these regions, with the highest rates being in Alaska and the lowest rates being in the Southwest. But that needs more study. So what are these risk factors? Family history is really probably the most commonly held risk factor for colon cancer. So overall, if one's lifetime risk is 5 to 6%, if you've got a parent or a sibling who had colon cancer, your lifetime risk increases to as much as 18%. And if you have 2 first-degree relatives with colorectal cancer, your lifetime risk can be as high as 24%. That's why it's so important to get those family histories. Obesity is a risk factor for colorectal cancer. We know that we have a weight issue across Indian country. Diet plays a major role. Diets that are high in animal fats and low in fiber and low in fresh fruits and vegetables have been shown to increase one's risk for colorectal cancer. Certainly in the late 60s, malnutrition was a problem on Indian reservations, and that's when the USDA Commodity Supplement Program came in, started bringing in a lot of food to Indian country, and really malnutrition was addressed by these changes. Unfortunately, here we are 50 years later, and we've replaced malnutrition with obesity and diabetes and cancer, these things that can come with this sort of diet. Not a lot of fresh fruits and vegetables over time, a lot of high-fat foods. Risk factors also include diabetes, and I think most are aware that diabetes is at epidemic proportions in our native communities. Daily smoking is also a colorectal cancer risk factor, and it's also a poor prognostic factor for individuals who develop colon cancer, as they have a higher rate of death once they're diagnosed. We also know that physical activity can reduce your risk of developing colon cancer by 40 to 50%. And a lot of the places where Native people live, reservations and things, the built-in environment in those areas make it a little more difficult for people to get regular exercise, rural roads and these sorts of things. And so not a lot of parks, not a lot of, running trails, these sorts of things to help keep people active. But overall, screening is definitely the low-hanging fruit. First, I just want to talk a little bit about the U.S. Preventative Services Task Force Colorectal Cancer Screening Guidelines. These were released back in 2008. And this slide is a little bit complicated and hard to see, but it's really a summary slide. If you look at the top, you'll see that they recommend, obviously, screening individuals between the ages of 50 and 75. Once people hit 76, we're not screening routinely, meaning that if they're up to date, say they had a colonoscopy at 75, they don't have any family history, that probably the benefit of continued screening is not there. However, if you do have adults in this range who have never been screened, and certainly if they have decent health status or are expected to live another 10 years, it'd be a good idea to get them screened. Over 85, the risks of screening usually outweigh the benefit. not a lot of folks over 85 who are really going to do well with chemotherapy and surgery if we do find cancers. So screening is not recommended. And I think it's really important to point out several things in terms of terminology. Screening means you're looking for polyps or cancer in an individual without any symptoms and who's never had polyps. If patients have had polyps in the past, that's actually, they're in the surveillance population. These guidelines don't apply to people who have had adenomatous polyps. And certainly if they're at high risk for colorectal cancer by way of family history, then those patients, again, are not in a screening population. They're more of a high-risk population. If you look down here, we see the tests that they recommend, either annual screening with high sensitivity fecal occult blood tests, and we're going to come back to that, or doing a sigmoidoscopy, which we'll talk about every 5 years, with high sensitivity fecal occult blood tests every 3 years, or doing a screening colonoscopy every 10 years. And again, this is a screening population. Let's talk a little bit about fecal occult blood tests. This is the Hemocult. This is a 3-card take-home test. How do you do this test? For those of you who don't know, really you have to do all 3 cards. Each card it has 2 windows. Each card is used to sample 1 stool. So you take a little stick in there, you smear some stool in these windows, you close it, and you send it in. And you need to do 3 of these cards from 3 consecutive bowel movements. Importantly, these go to the lab, they get developed. If they turn blue like this, then they're seeing occult blood. It does not mean the patient has colon cancer. It means there is some occult or microscopic blood in the stool, and that patient needs a colonoscopy. Should never, the reason we do this really ends up with 6 samples. The reason we do multiple samples, and this has to be done every year, is because, cancers and big polyps, they bleed intermittently. And so doing 6 samples, you're really increasing the odds that you'll find that. Again, I talked about the fact, they use the stick, they put the sample of the stool on there from 3 bowel movements. It's important to know with the guaiac-based tests like the Hemocult, there are a number of things patients need to be aware of. They have to avoid NSAIDs like aspirin, ibuprofen, naproxen, these things for 7 days. Tylenol is okay. We usually don't have patients stop their aspirin if they're just taking an aspirin a day. We also want them to avoid vitamin C and iron supplements, as these can give these can actually interfere with the test. We have patients avoid red meat for 3 days, as well as foods that are high in vitamin C, the citrus fruits and juices. So this is a lot for patients to think about. They have to alter their diet and their medications to get ready for this test. Some helpful hints, patients don't like to handle their stool. The stool shouldn't be allowed to touch the water. Couple ways to do this, you can put like plastic wrap over the toilet and shut the toilet seat. Make sure, obviously, you give yourself a little space for the toilet to go, the stool to go into. If you have an on-off valve right next to the toilet, you can actually just turn the water off to your toilet, flush it, and then there won't be any water in the bowl. Get your sample, turn the water back on, and flush it. In some places, we use the toilet hat. How good is this testing? With guaiac-based testing, we know if you do it every single year, you can reduce the mortality in a population from colon cancer by 33%. So you have to do it every year. If everybody did it every year, you would decrease colorectal cancer deaths by 33%. Unfortunately, if you do it every other year, you lose that benefit. The advantages of these tests, super inexpensive. You can do them at home. Most health systems can afford it, and it does decrease mortality. Limitations, again, you've got the food and medication restrictions. People don't like to handle their stool. You got to do it every single year, so you have to have systems in place to make sure that happens. And the sensitivity and specificity for colorectal cancer is a little, it's low, but it does have use, and it is a good test for patients who are really either unwilling or can't afford any other types of testing. There's very little preventative effect from this type of testing. Sometimes a big polyp might bleed, and this might trigger them getting a colonoscopy and getting those polyps out. This is one of the more critical slides. Back in the 80s and 90s, most of the colorectal cancer screening guidelines also accepted doing a guaiac, or looking for occult blood, in specimens obtained from a rectal exam. So the patient's in the clinic, doctor does a rectal exam, wipes a finger on a card, and they guaiac it. This was commonly done in the 80s and 90s. Back in 2005, a group called the VA Cooperative Study, which was a big bunch of researchers from multiple VAs, did a study of over 3,000 patients. All these patients did take-home guaiacs, did the 6-sample take-home test, and also had guaiacing done on rectal exams before having a colonoscopy. This is a busy slide, but I want to say of the 284 patients that actually had advanced neoplasia, meaning they had cancer or a big ugly polyp, the 6-sample take-home test was positive in almost 24%, but the digital rectal exam specimen was positive in only 5%. Only 2 out of 21 patients who actually had colorectal cancer had a positive test when they did this guaiac on a digital rectal exam specimen. So this has really been abandoned by all of the recommending bodies. There's been a lot of work out trying to get everybody to quit doing this. The newer test is the fecal immunochemistry test. It uses a little bit different technology. It actually uses an antibody which is specific to globin, which is a part of the hemoglobin in blood. It's more sensitive for lower GI tract bleeding because globin, as it travels through the GI tract, if you've got some blood coming from the upper GI tract, it's degraded. So, if you bite your lip or have a nosebleed, this test should not be positive, whereas, for instance, the guaiac or the typical guaiac hemocolts can be positive with those. How good are these tests? Again, a little bit complicated slide, but a couple large studies looked at how well FIT performs. They found that these FIT tests were positive in 54 out of 62 invasive cancers, compared to 46 out of 62 with the guaiac-based or hemocolt tests. And if they looked at polyps, people with large advanced polyps, again, the FIT test picked up 35.6% of these versus 18% who were doing the guaiac-based testing. And this just basically says what I said, that the FIT test actually does a little bit better job at finding cancer and polyps. The nice thing about the FIT test, in addition to its performance, is that it's a lot easier for patients to do. There's less stool sampling. There's multiple ways to do these. Some have a little plunger like in the picture up top where you just kind of plunge it in the stool and stick it in a little vial. Others use a little paintbrush where you paint the water next to the stool and put it on a card. But the things that are nice for the patient is that there really are no dietary modifications or medications to avoid. FluFit has been getting a lot of press lately. FluFit is a strategy that has looked at what happens if we give patients FIT tests, or these cards or vials to take home and do a stool test at the time they come in for their annual flu shot. And some very large studies have looked at this with Kaiser Permanente in California and others, and they've shown that they can actually increase screening by 10 to 20%. So 10 to 20% of those patients will actually send it back. Sometimes, though, patients might take that home, and they may not do it, but it also may prompt them to talk to their physician about colorectal cancer screening the next time they see them, saying, I got my flu shot, they gave me this card, I didn't know if I wanted to do that or not, what do you think about colorectal cancer screening? And boom, that might lead them to get screening. So that's one easy strategy to think about when you have your flu shot trial or your flu shot campaign. You might also give them these FIT tests. We'll talk a little bit about endoscopy. There's two types of endoscopy for screening. One's a sigmoidoscopy, where you look at the sigmoid colon, which is basically the first 3 feet of the colon. And then there's the colonoscopy, which requires you to clean out the whole bowel, but in which you look at the entire colon for polyps or cancer. Flex SIGs, again, detect individuals with polyps, so it can be preventable. Notably, if you see a polyp on a flex SIG, the patient isn't prepped, and so you can't use cautery usually, so larger polyps you can't take out. You biopsy them just to make sure they're adenomas. If they have an adenomatous polyp, they actually get sent for a colonoscopy. This method actually detects 70% of patients with advanced polyps and cancer. And the reason is a lot of times with patients who have a cancer on the right side of the colon, where they're not even getting to with the flexible sigmoidoscope, a lot of those patients end up having a polyp within the range of the scope that they can get to. And so they find that polyp, it triggers a colonoscopy, their colon cancer gets found. Limitations, it's not risk-free. Perforation and bleeding risks, as with colonoscopies, are very low. Flex SIGs are really not widely available. Because we don't give IV sedation for them generally, they are more painful than getting sedated for a colonoscopy. The other limitation, of course, is if you have a polyp, you need a full colonoscopy. The one thing I didn't write on here is that the major difference, too, is the prep. Patients for a flex SIG just have to give themselves some enemas. Because they're not getting sedated, they can drive themselves home as well afterwards. Whereas with the colonoscopy, there's a full day of preparation, cleaning out the bowel the day before, and patients have to have a driver because we give them sedation. And again, I just talked a little bit about this. A colonoscopy, of course, has the highest detection rate for colon cancer and polyps. You can take polyps out. It's the most preventative. Complication rates, again, are low but not insignificant. If we take polyps out, there's a 1 in 30 to 1 in 40 chance that site may bleed up to 7 days later. Sometimes we have to go back in and put a clip on it or deal with it. And even with the colonoscopy being the best test, there's still a potential for missed lesions. Studies have shown that we miss as many as 6% of advanced polyps. That's because it's not a straight tube. There's lots of crevices. Preps aren't always that good. You got big folds. Things can hide. Colorectal cancer trends, if we look at the incidence, we looked at mortality already. Again, we see this decreasing incidence or number of new cases predominantly in the white population. The American Indian Alaska Native is kind of the darker gray, kind of bounces around a lot because the numbers are smaller in those samples, and so they're not stable. But that's not a real significant trend in terms of decreasing incidence. This slide just kind of gives you an idea of what we as gastroenterologists recommend based on what we find in people's colons. If you have 1 or 2 adenomas and they're less than a centimeter big, we bring them back in 5 years. If you have 3 or more, we bring you back in 3 years. If you have 1 polyp over a centimeter, we bring you back in 3 years. And if the pathologist tells us that there's villus, it's a villus adenoma, those are higher risk polyps, we bring you back in 3 years. And again, these are patients that are in the surveillance population. These patients are no longer in the average risk screening population. A couple other screening methods out there. CT colonography, I thought maybe 7, 8 years ago that we'd be doing a lot more of this by now, but we're really not. CT performance for polyps over a centimeter, the sensitivity is about 90.9, so they miss about 10% of advanced polyps or cancer. The specificity is about 14%, but what I want to draw your attention to is the positive predictive value, which is about 23%, meaning that persons with a polyp on CT scan have about a 23% chance of actually having a polyp. They see things on the CT scan. It might be a stool ball that fell out of a diverticulum or something else they think's a polyp, and oftentimes those patients don't have polyps. Other issues with CT colonography, was not recommended by the U.S. Preventive Services Task Force, although those recommendations are due for an update. It's not covered by many insurance companies as a primary screening method. Oftentimes they'll pay for it if you have an incomplete colonoscopy or a patient that just can't have a colonoscopy for one reason or another. The CT colonographies are only as good as the experience of the radiologists that are reading them. And probably one of the biggest factors that's limited its use is just the accumulation of radiation. And so when you get a CT scan like this, it's the equivalent of getting between 200 and 250 chest x-rays. So it's a lot of radiation. If you start doing these repetitively to follow or look for polyps, that has been a concern. Cologuard has been in the news a lot lately. This is a newer test. This does both a FIT test and also looks for some DNA in stool samples. And this is actually what the kit, kind of like a cartoon of what the kit looks like. It comes in a box. The sample container and the bracket are used to collect the sample. That bracket sits on the toilet. The sample container, you take the lid off, you put it in there, and you put your stool in there. After you're done, you have to use a little probe to get a sample of the stool and put it in that little tube vial. You also then add that bottle of liquid preservative and mix that up in there, put the lid back on, put it in the box, fill out all the sample labels, and then it has to be FedEx or UPS shipped to the company so that it arrives within 2 days. It's a pretty good test. The data shows that it catches colon cancer and rectal cancer. Its true positive rate is 92%. It seems pretty good for polyps at 69%. But there's also a 13% false positive rate, meaning 13 people out of 100 who do it are going to have a positive result that actually don't have either of those things, and they will get sent for colonoscopy to prove that they don't have anything. Bigger problems are it's not covered by most insurance yet. And the cost is still $600, and patients may be averse, again, to the stool handling and shipping. Lastly is the dual contrast barium minima. This really isn't used much by anybody for screening anymore. It's really a test that we use if you say we can't get through a sigmoid colon because of the anatomy or something else is going on, or the patient's just too old and sick to even do a bowel prep. We may do a barium minima just to see if they have a lesion in the colon that may be causing some other symptoms like progressive constipation. So, which test is best? The answer is pretty simple. It's the one that actually gets done. So, rather than focusing on what's the best test, we need to focus on the ones that the patients will do, and we need to focus on the ones that the health system can actually afford and the patients have access to. This slide shows colorectal cancer screening rates by age from individuals 51 to 80 by IHS area. And you'll see that we have a pretty big variation in terms of the proportion of the population served by the IHS that gets screened. It's lowest down in the Southwest. Alaska, because of their high rates, have been very proactive with colorectal cancer screening. And literally, if they can do it, anybody can, if you think about their geography and the things they have to do to get people screened. While if you look all the way to the left, you see that the U.S. population, about 65 to 70% of patients are current with colorectal cancer screening. Overall, IHS is 42%. This was in 2011. These rates have actually been improving. And if you look back at when I started in the Northern Plains, we knew that our screening rates were between 16 and 26%. And within 5 years and a lot of work, we've got that as high as 47% in the Bemidji area. So things are changing and things are improving. Why are screening rates low? Well, certainly there are a lot of patient factors, cultural factors, community factors, health literacy factors. We also have a lot of health systems factors that we can improve on. And as everyone knows, there are financial factors that can be barriers. In terms of a strategic plan, we've had a lot of luck with different health systems trying to use navigators. Navigators are individuals that are in the community, often community members. Rosie Morgan is actually she was a breast cancer survivor up at Red Lake in Minnesota, and she developed an interest in colorectal cancer screening, and she bangs on doors, she gets casino cards, she bribes people to get screened. She's a source for people to learn more about screening, and certainly navigators can really help improve your screening rates. Having providers who recommend screening has been shown to be the strongest predictor of screening in multiple studies and in multiple populations. So we have to have doctors who are recommending, you got to get screened. So just take-home points so far. Colorectal cancer is the second leading cause of cancer mortality behind lung cancer. Screening and surveillance can prevent both cancer incidence and mortality. Screening starts at age 50. Unless there's a family history, then we actually start screening lower. And we should not be doing these guaiacs in the office on digital rectal exams. They've got to be the ones that you take home, and you have to do them every year if you're going to use that method. So if you think about colon cancer screening, you have to have several components. You have to have a willing patient, you have to have access to care, and you have to have an enabling health system. And when all those things work together, you get individuals who get screened. Last bit of this talk, I want to talk about the IMPACT study. IMPACT stands for Improving Northern Plains American Indian Colorectal Cancer Screening. And this was a project that was funded through the Indian Health Service. It was actually the first major project of the American Indian Cancer Foundation. It was a 2-year project, and what we did is we aimed to conduct site visits at IHS and tribal health systems. We wanted to look at colorectal cancer screening practices, everything from, do they have patient tracking systems and provider reminders. We wanted to also work with the providers and assess their knowledge and attitudes and beliefs and look at the challenges they had in getting people screened. The framework for the project was this publication, which if you don't know about it, is an excellent resource. This is put out by the American Cancer Society and the National Colorectal Cancer Roundtable, and it's called How to Increase Colorectal Cancer Screening Rates in Practice. And it's available free. It's online. You can download the PDF, and it has a lot of great strategies in it for increasing screening rates. Our scope, again, was the Northern Plains and these states, and we actually approached 54 different sites to participate. First thing we did at these sites was a facility assessment questionnaire. We looked at numerous things, the staff duties on screening. We looked at, do they have an existing screening policy? What kind of methods do they use to identify patients who needed screening? Were there provider reminder systems? What methods were used to counsel patients about the screening options? Did they have a patient navigator available? We also looked at, do they have systems to capture whether patients were actually completing their stool tests and sending them back? Were they tracking results from endoscopy? And did they track those pathology reports and those sorts of things? Secondly, we looked at provider questionnaires and did some focus groups with providers about their beliefs about colorectal cancer screening, when they started patients for screening in terms of their age, what tests they use, perceptions about screening in their communities, and how their clinical systems functioned to promote screening. Again, we approached 54 different sites, and 40 of them actually completed the project. About, I guess, 13 for various reasons weren't able to actually participate, but we thought that was a pretty good catchment. We actually met with 431 health professionals, including 145 health providers. So let's look at the results. We look at the results in the context of the 4 toolbox essentials from this publication. The first says providers must recommend screening. We know from state surveys that 90% of people who actually get screened tell us that their doctor told them to. Only about 17% of people who said that their doctor has never told them to get screened actually get screened. So again, doctors have to tell their patients to get screened. And we asked these providers about that, and 90% said that they are routinely assessing patients and their colorectal cancer risk factors and their screening history. We asked what age do you initiate screening, and most individuals knew that screening should start somewhere between age 45 and 50. 50 is the actual guideline. And almost all of them knew that if you had one positive fecal cold blood test or FIT test, the patients needed to be sent for a colonoscopy. So it was good. However, we also asked, do you ever guaiac digital rectal exams specimens for screening? And 65% of the providers said they did that. And again, we talked a little earlier that this has been a practice that everyone has been trying to really get rid of at the national level because it doesn't work and it gives patients a false sense of security that they were screened. Toolbox essential number 2, we asked you, do you have a colorectal cancer screening policy? Those policies really need to, look at colorectal cancer risk and look at local resources and payer coverage. And there really should be a comprehensive protocol for tracking and results communications. Unfortunately, 90% of the places we went did not have any sort of established screening policy or flow chart of how patients get tracked and lacked a lot of that infrastructure. We asked about reminders, both patient-oriented reminders and provider-oriented reminders for screening. And we found that just about half actually had a system to remind providers when patients were due for screening at the clinic visit. So patients sitting in front of you, is there something there reminding the doctor that they're due for colorectal cancer screening? Only half of clinics. We asked, is there a system that reminds providers when patients are due for screening when they're not in clinic? Do they get a printout every month that says, these are the patients in your panel, and they're overdue for screening? And only 25% of clinics had something like that. We asked, do you use your electronic medical record to track when screening's due? And only 37% of those who have an electronic medical record system actually did. We asked, does your facility give providers feedback on their screening rates? And about half did. We asked, does your clinic send reminders or call patients when you send them home with a stool study and they don't send it back? And only about 1 in 4 of those did. So lots of ways to improve these rates. We asked, how are patients tracked for repeat screening or surveillance? In other words, they're due for it again. And about half of places didn't do any sort of tracking. Then 18% used some sort of paper record, and about a third kept that information in their electronic medical record. How are patients reminded when the subsequent screening or surveillance is due? About a fourth, there is no reminder. You're due for another colonoscopy, but it's up to maybe the doctor sees a chart when you come in and maybe picks up that in his in his visit with you, which may be covering all sorts of different things. Very few were doing any sort of telephone call or mailing. So most of them just kind of relied on that face-to-face visit and that doctor, half the time not having any sort of prompt, figuring out that you're due for screening again. Lastly, the last essential was to have an effective communication system, and this really looks at decision stage-based communication, shared decision-making, and staff involvement in trying to improve colorectal cancer screening. And we asked, do your patients usually just want you to choose a test for them? And interestingly, 82% of the doctors said yes. Lastly, we asked the providers, how much time do you think it really takes to talk adequately about screening? And about half thought it really took less than 5 minutes. There were providers who really felt it took a lot of time to really go through this and explain everything to patients. Overall, 39% of the providers we talked to believe that clinic time demands limit their ability to discuss screening options with their patients. So what are the recommendations based on all this data that I've shown you? And know it's been a lot. Again, all health systems should develop and have a clinic policy. And these policies should be based on national guidelines. And again, this publication is a great tool to help you develop those types of policies. Policies should include how are you going to identify the patients who need to be screened, how are we going to identify what their risk is for colon cancer based on their personal and family history, a method other than just simple clinic catchment for making sure patients are aware that they're due for screening, and how are they going to, how screening needs and risk will be made readily available to providers during their clinical visits and outside that. Other policy, other important things to have in your policies are teaching aids that are available to providers, a method for tracking screening discussions and patient choices, and procedures for tracking ordered tests for completion. Again, provider recommendation is critical. We have to commit to recommending screening to all appropriate patients. Providers need annual training on current screening recommendations. And providers really need to practice helping patients make informed screening decisions so they can do that in an efficient way. So in other words, being able to have a good conversation, but doing it, in 5, 6, 7 minutes so that it doesn't eat up all their clinic time. What does that mean? That means engaging your patients to talk about screening. If there's not enough time to talk about it, to schedule a visit for this purpose, and making sure that we're tracking screening recommendations and completion rates by provider and using that feedback to help the providers to increase their screening. Clinic reminder systems are essential, whether it's a paper chart with just a face sheet that lists, when they had their last test and when screening's due, or incorporating it into your electronic medical record system. We need to implement communication systems. Again, we got to contact patients when they're due to have their repeat fit tests or their FOBT. We have to contact patients when endoscopy appointments are not completed to either reschedule those or offer another means of screening. And that's really what I've got. Thank you for your time.
Thank you, Dr. Perdue. If any of the attendees have questions, please type them into the chat box. We have a few questions already. Let's see here, from Gina Marie Farino. If a patient has a positive FIT test, they are then referred for colonoscopy. Is this considered a screening or a diagnostic colonoscopy? Because the distinction has ramifications with regards to insurance coverage, cost sharing, etc.
This is a ridiculous component of insurance that is being fought at multiple levels. So the question really is an insurance question. So if a patient comes in, how is it coded? Is this a screening test or is this a diagnostic test because they had a FIT? And the answer is that it varies by how the insurance company looks at it. So, just from a practical standpoint, if the patient is sent to me for a positive fecal blood test, that becomes the indication for the procedure in the chart. How that is handled by insurance companies varies. Some will still say, okay, this is screening, there's no copay, or we're covering all of this. Others say, oh, this is now a diagnostic test, and the free, the no copay or the free colonoscopy no longer applies. Unfortunately, what you have to do is that people have to check with their insurance company. I think it's ridiculous. I mean, the intent still needs to be screening.
Thank you. The next question is, what are some culturally competent messages that can increase colorectal screening?
Well, I think that's an important topic that I didn't talk a whole lot about, and we didn't really get into kind of the community barriers. You have to think about what are the community barriers to screening. Number one, people are busy. People have, they may be providing child care. They may not have transportation. These things can all play a role. People may have, great Uncle John who had a rigid sigmoidoscopy back in 1968, and it hurt really bad, or he had a perforation, and so these fears get kind of trickled down. But I think you have to have a good feeling for what will resonate with your target population. We know from some of our work that elders tend to not be motivated as much about, you need to do this for you, you need to do this to make sure you're healthy. They tend to be more motivated by messages such as, you need to be around to be able to, teach our ways to your grandchildren, to be there for them, to help the family. So a lot of times people can be motivated again by focusing on the family unit and not so much themselves. A lot of the reason people don't get screened is they're afraid. They're afraid that something bad is going to be found. They're afraid to talk about colorectal cancer. They're afraid of what will happen. And so overcoming fears is really important. It's important to get the message out that most of the screening is really looking for polyps. It's rare that we do a screening colonoscopy and actually find colon cancer. we do find polyps in 1 in 4, 1 in 5 people. We take those polyps out, and we know that decreases your risk for cancer. So those are some ideas.
Thank you. And next question is, what are the best approaches to fostering relationships with reservations to introduce people to healthy messages?
One more time? That sounds like a title for a whole talk.
It says, what are the best approaches to fostering relationships with reservations to introduce people to healthy messages?
Yeah, so I think, that's a broad topic, but it's I'm taking it that may be coming from somebody who doesn't work within a tribal health system. One of the most important, I guess, components of doing that is you really have to go in with the attitude that you're helping Native communities find their own solutions to their own problems. The message that we're going to bring all this stuff in and we're going to help you do these things, that's an old message, and as my dad would always say, that dog doesn't hunt very well. So partnering, coming in as a partnership, really promoting the fact that we want to be, if you're a non-tribal entity, we want to be a resource. We want to help you find your own solutions to your own, colorectal cancer disparities or other health issues. That's much more likely to be accepted and to be embraced than, we got grant money and we're here to save you and we're here to get you screened and those sorts of messages.
Great. The next question is, does IHS pay for Cologuard? Does Medicare pay for this type of test?
So it's getting fast-tracked. Last I heard, I think it's pending. It got through things, and I don't know exactly because it's really only come out in the last month, in terms of it got fast-tracked with the FDA. I think it probably will be covered by Medicare pretty soon, but again, it's spotty because it's so new. They're going to need to do more cost-effectiveness analyses on it. Interestingly, 7 years ago, HRSA, the federal entity, did a cost-effectiveness analysis of fecal DNA and really felt the cost needed to be around the $80 range to be cost-effective, and this one's $600. So, more people do it, maybe the cost comes down and it becomes less of a barrier. As insurance covers it, maybe it becomes less of a barrier. If it's a test that more people will do and actually get screened, people that just don't, there's no way in heck they're going to have a colonoscopy, and this is a way to get them screened, then, more power to them. People kind of, they're a little more willing to have a colonoscopy once they got a positive test that something might be going on.
Thank you. And the next question is, what do you know about the Affordable Care Act coverage for colonoscopies after a positive FIT test in the Native population?
Well, again, so, I mean, that the health promotion, Obamacare, let's just use the word everybody else uses. Obamacare lays out recommendations for what and policies that the insurance companies are supposed to cover. But still, I think a lot of that is being worked out. And when you're talking about the Native population, you're talking about multiple payers. So you've got Indian Health Service paying for some people. You've got tribal health compacted, getting IHS dollars, making decisions about what they're going to pay for. You have individuals who have private health insurance. Maybe they're working for the tribe or working for the casino, and they've got, they've got commercial insurance. So again, it's going to vary a lot by individual and by health system as to what's covered. And again, if you talk about, what is the cover like if you get a FIT first, again, you have to, it's going to vary by insurance company. So it's hard to answer that question directly.
Okay. Thank you very much. And the next question is, what did Alaska do that increased their screenings?
That is a great question. So Alaska has done a lot of innovative things. Again, you're talking about a very rural population. You're talking about a population that if you want somebody to get a colonoscopy in the winter, they've got to, some people have to get on a snowmobile, ride it 20 miles to a little regional airport, take a little regional airport to a bigger airport, and take a bigger airplane to Anchorage, which is the only, health facility that has, to my knowledge, colonoscopy. They've been doing some flex SIGs at Some of the regional health centers actually had a project where they were training nurse practitioners to do flex SIGs. It didn't work out so well because there were a lot of turnover, so people get trained, they'd be doing it. Maybe there were other time demands, or maybe the nurse practitioner wouldn't stay there very long. More recently, they've been doing kind of a mass unit approach where they actually do outreach. They'll fly in a surgical team and do a bunch of screening colonoscopies. They don't do a lot of fecal occult blood tests because they have a very high rate of H. pylori, which is a bacteria that can live in your stomach and give you can give you blood in your stool, essentially. So the older guaiac tests don't work. We recently published a project looking at FIT tests in that population. It looks like it might be a good alternative that might be a little bit better for the native population in terms of looking at blood. And I know they've got actually a study going on right now with Cologuard with Dr. Alquist from the Mayo Clinic. So they're looking at different ways to do that. They have, a lot of these villages have health educators and navigators. They're out there working and getting people to get screened. So they've done a lot of things. They've developed culturally tailored educational programs, videos, pamphlets. They've attacked it every way they can.
Thank you. The next question. If you have a negative screening colonoscopy with a repeat in 10 years, should you do FIT tests in between?
No.
Next question. This webinar has been a great session to build our knowledge base. Will IHS bring more awareness campaigns?
Yeah, I think the IHS Task Force is always looking at ways to try to increase screening uptake. The one thing I didn't say about the impact study is we actually, when we went around to those 145 providers, we did in-services, we did presentations on colorectal cancer screening and appropriate screening, trying to get the knowledge base up. There are, I think there's still a lot of different organizations who are getting involved in trying to increase screening.
Thank you. I also have a statement here. It says, "Thank you, Dr. Perdue, for opening up with the commodity foods and its impacts." And,
all right.
Is there any more questions? That appears that would be a negative.
Excellent.
Well, thank you again, Dr. Perdue.
I still have 3 colonoscopies to go do today, so. Thank you very much for having me.
Thank you. Thank you for attending the National Native Network Technical Assistance webinar. If you would like to see other topics offered, please use the evaluation survey and contact us on our website or Facebook. The post-webinar survey will come to you by email within the next 2 days. Your input is important and appreciated. Visit www.keepitsacred.org to find this webinar, other archived technical assistance webinars, and many other cancer and commercial tobacco prevention resources for Native American and Alaskan Native tribes and tribal organizations. Miigwech. All right. Let's see here. Thank you very much, Doctor.
You're welcome.
And that went very well, if I say so myself.
Awesome. All right. Thanks for having me.
Thanks, and have a great day, guys. Enjoy your holidays.
All right. Thanks. You too.
Bye-bye.